Good afternoon, everybody. For the afternoon session, which comprises of panel discussions, for the first session we have with us, our speaker is Dr. Amjad Maniar. He'll be talking on putting the shoulder to the wheel. The panelists for this discussion, the speaker is Dr. Amjad Maniar, moderator Dr. Shishir Agrawal, and the panelists will include Dr. Amjad and Dr. Siva Shanmugan. For the surgeons, we have Dr. Abhisar and Dr. Gaurav Rathore. And from the physiotherapy department, we have Dr. Ramesh.
Good afternoon, everyone. I have this dubious distinction of either getting my talk before lunch or after lunch, and this seems to have followed. So we'll be talking about the shoulder today. You saw plenty of blocks from the theatre this morning with relation to the shoulder. So we'll look at a few concepts, the need for effective shoulder analgesias, a little bit of anatomy, what blocks we have in our armamentarium, and hopefully you'll have a few tips to take away and some idea of about how you go about providing analgesia for shoulder surgery. Now, shoulders are pretty painful. You've seen that even if the surgeon does minimal rotator cuff work, it is very painful, it can be very distressing, and many patients come with chronic shoulder pain, chronic shoulder immobility, which requires them to undergo a series of physiotherapy sessions that are extremely painful. So in terms of surgery in the operating room, there we have many regimens on how to manage the pain into the surgery as well as in the post-operative period. And it's undeniable that regional anesthesia is going to play a huge part in what we do. But what you want is quick, successful and non-complicated regional anesthesia techniques. You saw today when Shiva did the block, we were done very quickly, no nonsense, done the block and the patient is ready for surgery. And if you run busy operating rooms, this is what you want. You want to be very efficient and you want to do quick and effective blocks without causing problems to the patient. They've already come to the hospital with enough of problems. You don't want to be the one creating more problems. So there are a lot of surgeries these days around the shoulder, and you might have, these names might look very familiar to you. Our surgeons have gotten more and more talented and skillful. They are able to pull off most of these surgeries with the arthroscopy, which is minimally invasive. But every now and then you'll also get the proximal humerus fractures, which is an open surgery. So these are the things that you take into consideration when you do the analgesia for shoulder. Now the shoulder joint is a marvelous joint. I'm sure our orthopedic friends here will agree that it is one of the most dynamic joints which offers a fantastic range of movements. But to do that, it also becomes complicated. It essentially is it is two joints there, the acromioclavicular joint as well as the glenohumeral joint, where the scapula articulates with the humerus. Now usually there is something known as a capsule that covers this, and the capsule covers the rotator cuff, which is formed by the ligaments, the tendons of the supraspinatus, infraspinatus, the teres minor and the subscapularis muscle. Don't break your head too much into the major anatomy of the shoulder joint. This is something more for the surgeons, but when you hear these names, they need to be familiar for you as an anesthesiologist. Again, these muscles, the rotator cuff is covered by the deltoid, and the biceps also offers a sort of a pulley mechanism for the glenohumeral joint. And there are plenty of ligaments that are present. These are again part of the structure of the joint, and these are usually the targets of repair when the surgeons are operating. There are also plenty of bursae around the shoulder joint. These, along with the synovial fluid, help in mobility, and they form as a cushion between the joint structures. Okay, these are also places that are targets for the surgeries. So what we are interested most in is the neural supply to the shoulder. What nerves supply the shoulder and what can we do to prevent them from transmitting pain? If you look at the all familiar image of the brachial plexus, you find that there are actually 4 nerves that supply the shoulder joint. The suprascapular nerve and the axillary nerve are the 2 main components of the shoulder innervation. Apart from that, the lateral pectoral nerve and the pair of subscapular nerves, the upper and lower subscapular nerves, are the 4 nerves that intimately supply all the little structures that make up the shoulder joint. If you're looking at the skin on top of the shoulder or close to where the deltopectoral groove is, this is covered by the supraclavicular nerve. You saw Shiva block the supraclavicular nerves this morning. So that is something that you must target if you're looking at the port sites or the incision on when you do an open proximal humerus surgery. So this is how the dermatome map would be. The supraclavicular nerve is shown over here on the top of the deltoid, and the axillary nerve usually covers both the anterior and the posterior sides lower down. When it comes to the osteotomes, the suprascapular nerve and the axillary nerve, you can see the suprascapular nerve covers a lot of the scapula muscle. Just one moment. And the axillary nerve supplies the area which is the proximal humerus. The subscapular and the subclavian nerve actually have much lower roles, but many people believe that they can contribute to the soft tissues within the shoulder joint, and at some points they may be important to block. The shoulder joint structures have both nociception and mechanoceptors. We are more interested in the nociceptors, and the aggregation is more at the supero-posterior area of the capsule. The anterior side has more of mechanoceptors. Only the coracoacromial ligament is aneural, so probably not very painful, but all the other ligaments are richly innervated with nociceptors. And the density is increased when there is more inflammation, like in a rotator cuff disease, so this becomes more and more painful, so we definitely have to do something about it. But the highest aggregation of these nociceptors is in the subacromial bursa. There are just some points for you to remember and know when you're dealing with these sort of pathologies. So if you try to aggregate all the little structures, those little ligaments, those tendons, those bursae, the bone, this is what it would lay out. The shoulder joint would lay out into this, predominantly with the suprascapular nerve, the subscapular nerve, and the axillary nerve here. So it's all mixed. So sometimes there has been of late people have told you, they will tell you to block individual nerves, but you find that in such situation it may not always be a good idea to do it, and then you will wind up with 4 injections. So it's something for you to think about when you look at how the nerve supply is distributed. So summarizing that, we have 4 nerves to deal with, or 4 nerves to deal with. The good news is all these neural elements come from C5 and C6, which is why traditionally the interscalene block has been the go-to area. And in today's day and age, there are a lot of places where you can put the local anesthetic to block this end target of 4 nerves. There is the interscalene area, we are well versed with it. It's C5, C6 area, that's the ventral rami of C5, C6. It's not the roots, it's the ventral rami that comes out. We've seen the upper trunk block today, that's another area. That's again a very nice little area to do it in, because it's far away from where the origins of C5, C6 are. Then of course there is the good old supraclavicular, which many people, for the upper limb, that's the only block they like to go to. That can be done for shoulder. The suprascapular nerve in isolation in the anterior area is another place to go to. The costoclavicular area has been also described for a target for shoulder analgesia. And even the infraclavicular area has been a place where you could go to. But this in combination with the suprascapular, we'll get to there as we go. And in isolation, you can block the axillary nerve also in an isolated structure far away. But I'm not going to tell you about block techniques. You've seen a lot of blocks today, so I'm not going to talk to you, but I'll talk to you about a little bit about each block and what they bring, and the main reason why these talks happen in conferences is because of the phrenic nerve, and we'll get to that. So the interscalene block is an old block. It's been around for a long time, but among all the blocks that we have in regional anesthesia, the interscalene and the lumbar plexus are the most notorious for causing complications. Some complications are Horner syndromes. We see that every now and then. If you go in too medial, if a needle is directed too medially, you could have central neuraxial spread. But the whole thing boils down these days to how much of the phrenic nerve are you getting when you do an interscalene block. And pretty much every time you do an interscalene block, with whatever volume you do, you will get a phrenic nerve blockade. So when ultrasound came along, we started reducing the volumes. In the old days, they used to go up to 40 or 50 ml, but now we probably don't exceed 20 mils. It has come down, but it has not been obliterated. Now, one thing you should know, and when we make these concepts for shoulder analgesia and blocks of the brachial plexus, as we depart from C5 and C6, the distance between the main brachial plexus and the phrenic nerve increases. Not by much, but it increases. Alright, so going away from C5, C6 in the interscalene is good. It reduces the rate of phrenic nerve blockade. So where is the phrenic nerve in relation to the interscalene? So if you look at C5, the phrenic nerve can be as close as that. If you scan a little higher, you might find a little twig of the phrenic nerve coming out from C5 also. The blockade of the phrenic nerve can be transient because of your local anesthetic, but if you get your needle in the wrong way, it's possible that you could damage the phrenic nerve because it's sitting right there. You can imagine an out of plane needle coming in down there and damaging the phrenic nerve, so the palsy can be persistent. And if you've done a fair bit of these blocks in your practice, you would have encountered it every now and then. Any of you encountered phrenic nerve palsy? You can raise your hands. Yeah. So it can happen and it'll hit you at the wrong time. So you have to keep an eye on it when you do it. So with the advent of ultrasound, some strategies came along that said that maybe if you do this, you could reduce the phrenic nerve palsy. So the prime strategy that started out was reducing the volume of local anesthetic. At the most in my practice we give about 10 or 12 mils of local anesthetic, and that gives a great interscalene block. Lower the concentration of local anesthetic, so instead of getting a dense block of the phrenic nerve, you probably wind up with a lighter block of it that would also resolve faster. You could put in a catheter and intermittently bolus with low volumes. Some have proposed that injecting outside the fascia that envelops the brachial plexus could be advantageous. Some have also proposed that you do the injection lower down at C7 so that the local doesn't track upwards. So these are all different strategies. But in 2007, Darcy Price proposed something very radical. He said, let's just not go near the interscalene, let's just block the suprascapular nerve as well as the axillary nerve. And he did this in a clinical trial of about 70 patients for patients who underwent arthroscopic as well as open shouldered studies. And he came to the conclusion that it offers good analgesia, but not as good as the interscalene, but sometimes we can take that, right? So this is how an anterior suprascapular approach would be. If you scan lower down, you see the formation of C5, C6 into the upper trunk, and as you scan towards the supraclavicular area, you'll see that the suprascapular nerve will take off and leave the body of the brachial plexus in the supraclavicular area. So you can isolate the suprascapular nerve and block it there with a very small amount of local anesthetic. The axillary nerve is again an important component of the proximal humerus osteotome that you saw, and this can be blocked in the quadrangular space at the back of the shoulder. Again, these are isolated and distal blocks. Do they work? There are plenty of reports in the literature regarding them, and most of them will tell you that they do work, but they're not as good as an interscalene. So you'll have to be very careful when you choose these blocks to perform. Now, if you go down, you saw today that we did these superior trunk block, right? So that is again a little distal from where the C5, C6 is, and if you look here, C5, C6 will join to form the superior trunk. Now this is farther away from the phrenic nerve, so putting an injection over here is going to reduce the rate of blockade. So this was one of the earlier articles which said that 15 ml ISB versus a 10 ml superior trunk block, the rate of phrenic nerve paralysis is 71% versus 5%. It's still not zero, but it's a lot less. And the quality of analgesia with these blocks is pretty much as good as that as an interscalene. So there's definitely one advance that has worked very well. Shiva has put out this paper on the SCUT block which you saw today, where he proposes that with a single nerve needle entry you could block both the supraclavicular nerves as well as the upper trunk or the superior trunk, and this provides great analgesia. So coming to some of the other approaches, the supraclavicular has been used for a long time. People still use it for shoulder surgery, and this is one of the most investigated blocks apart from the interscalene for shoulder surgeries. And there's this two papers by Tran in 2017 and 2019 where they follow the different blocks and the complications that happen with them. So it's something good for you to look at. So again, the phrenic nerve blockade is still about 60% when you use traditional volumes with the supraclavicular block. It's an option, it's not 100%, but it's something that is considered, but it's not very popular. One of the newer blocks that was described probably about 8-10 years ago is the costoclavicular block. It's more of a medial infraclavicular block. Now this is an area where the cords of the brachial plexus are formed. This is just below the clavicle and the cords are formed, and blocking this would give you blockade of the subscapular nerves, the axillary nerve, as well as if you move a little lateral, the pectoral nerves will be blocked. But it doesn't explicitly block, it doesn't directly block the suprascapular nerve, because the suprascapular nerve, as you saw in the early image, takes off early. But since this block is clustered, the cords are clustered within the sheath, there is upward spread if you give sufficient volume, and this should be able to block the suprascapular nerve. So this is one of the popular blocks that is being investigated these days, but remember that you are not directly blocking the complete neural elements for the shoulder, but you're relying on an indirect spread to block the suprascapular nerve, which contributes something like 60-70% of the innervation to the shoulder. So again, from that Tran article, he looked at all the approaches and he looked at the involvement of the phrenic nerve. So basically what he said was none of the approaches will prevent you from having 100% from blocking the phrenic nerve. Though there is one article that says the costoclavicular block does not get the phrenic nerve involved. This is just one article that says so. There was another article that came out a little later that says that there is still about a 5 to 7% chance of blockade of the phrenic nerve. So none of the approaches that we have is really reliable in preventing the blockade. So over the past few years there have been a couple of other techniques that have come out. One of them is to, if you're blocking the suprascapular nerve independently and you're blocking the axillary nerve independently, you can block the lateral pectoral nerve by doing, the PEX1 block. It's just an injection at the lateral side of the clavicle between the pectoralis major and the pectoralis minor muscles. So it's a similar view that you get when you scan for the infraclavicular. You just drop about 10 mils of local anesthetic between these two muscles and you would get lateral pectoral nerve block. Another block that was proposed is for the subscapular nerves. Now how do we do it? It's a little weird. It's not the usual sort of technique. You sit with the patient shoulder here, and you do a scan of the upper end of the humerus and identify these targets, the greater tuberosity, the intertubercular groove, and what you will see is a little muscle over there. That is the subscapularis. So if you look closer at that, if you move the probe a little more medial, injecting in this plane over here, I don't know if you can see my pointer. Okay, I think I should get the pointer. So injecting into this plane between the pectoralis major and the subscapularis is known as the subscapularis plane block, and this will effectively block the subscapular nerves as well as the axillary nerve. So you're getting 2 out of the 4 blocks by just putting the local there. So this is another thing for you to consider. Now there's another whole big mess up and a big conglomerate of different combinations that you could use. You could do an anterior suprascapular block and an axillary nerve block. You could do the traditional posterior suprascapular and an axillary nerve. You could do a suprascapular and a subscapularis plane block, which I just showed you, which would block at least 3 of the 4 nerves. You could do a suprascapular and just block the posterior cord in isolation by scanning in an infraclavicular area. You could do suprascapular and the whole infraclavicular. So there's a whole lot of different combinations that you could use. So what is the best thing? So many of the papers and the studies, they talk about the block, but they ignore the patient as a whole. And one of the main things that you should be doing as an anesthesiologist is trying to predict which patient is at risk for your technique. And when you get patients who have acute or chronic respiratory disease, who are orthopneic and dyspneic, patients who are obese, patients who have short neck, these patients are prone to having problems when the phrenic nerve gets involved. But what about the regular? Today you saw a couple of patients who we weren't really too bothered about the phrenic nerve because they had no respiratory issues. And if you look at these patients, the young patients who come for shoulder surgery, you'll find that you can get a 30 to 40% reduction in FVC as well as FEV1, as well as the 2 papers that have shown that it's a very significant decline in these respiratory parameters. But symptomatically and clinically, nothing happens to this patient. They do very well, which is why most of the time you do an interscalene block, you give 20 ml, then nothing happens, everything goes well. But if you have a compromised patient, these small changes can actually sink the patient. So it is very important for you to look at the patient as a whole, examine the patient, check if the patient can lie flat, check if the patient has chronic issues or even a trauma. If the patient has a pneumothorax or something like that, these patients will sink after the block. So you'll have to think twice and adopt some of these newer practices if you want to use RA on these patients. So what should you do? So the targets for analgesia and recovery after shoulder surgery are fairly consistent. You don't have surgeons asking you to get the patient to move, do exercises, do things like that. So you get a good 24 hours where the patient is just going to stay still and rest. So there still is a scope for the interscalene in our current clinical practice, because moderate phrenic nerve blockade may be clinically insignificant in healthy patients. But like I said, next time you see a shoulder patient, ask these questions whether this patient is going to be all right with an interscalene block, because you can be pretty sure that the phrenic nerve is going to get blocked. So any more questions and stuff, we will deal with it during the panel discussion. Thank you.
Thank you, sir. May I request Dr. Shishir to kindly take over and initiate the discussions?
Good afternoon, dear friends. It was a very... Anshuman is a very great organizer. I know him pretty well, and it was a great show since morning I saw. So, Amjad is a very good speaker. I know he's a very good speaker. Since around 4 or 5 years, every talk which I see, it is excellent. Now I want to see, is he a very good clinician as well? Okay. Now my panel discussion is shoulder surgery. So shoulder joint, very painful joint. It is a very painful joint, and it is just like a goddess of the all joints. And all of you panelists are angels. They are all like angels. Two surgeon, two anesthetists, and one physiotherapist. We have a very great team. Now coming to a real case scenario, this is a gentleman, he is having history of left shoulder pain just last 2 years. This pain worsens at night time, and it is associated with sleep disturbance, weakness in abduction of arm, and shoulder rotation. 2 intra-articular injection already received, and history of IgA nephropathy, for which he is on ACE inhibitors, ARB, along with dapagliflozin, and for which surgeon is planning arthroscopic repair. And this is the MRI report of the patient. So there is 60-70% of the partial tear of the supraspinatus ligament, and name of patient is this. So I myself is the patient. And when my surgeon told me that he is going to perform this surgery, I was very anxious. So, all of you, can you suggest what will be the best anesthesia plan for me? Dr. Amjad, can you suggest what you are going to offer me in all of?
You tell me what you did then. You tell me what you did. Patient survived, no? All of you went home on the same day, no? Patient, surgeon, and anesthetist. So you're saying that the patient is anxious?
Yeah, I'm very anxious. Myself is patient.
Oh, you're the patient.
Yeah.
I thought the anesthetist was anxious.
Myself is patient.
Yeah, so the surgeon is planning an arthroscopic repair. Okay, so you ask the patient, are you okay to stay awake? Do you want to stay awake, or do you want to
I
sleep?
am very anxious. I already told you.
I'm asking you, are you happy to stay awake during the surgery, or do you want to sleep? Which one do you think
My
is
surgeon
nicer?
usually he shouts a lot.
What surgeon? Who shouts a lot?
My surgeon he shouts a lot during surgery, his surgery.
All right. Okay. All right. So I think the best thing for you would be to go to sleep during the surgery, because we don't want you getting up and we don't want you being anxious. So general anesthetic will be one part of it. Now next thing I'll ask the patient is, would you be all right if I give you a small injection at your neck before the surgery?
Definitely. I can bear that much pain.
You can bear that much pain. Do you think you'll be able to manage and go home in 24 hours, or do you think you're going to need some sort of analgesia for longer than that?
Yes, definitely. I need a very good analgesia after the surgery.
But for how long do you think? The surgeon says he's going to send you home tomorrow. Do you think you can go home tomorrow?
I want analgesia till the time I recover.
Okay. So I'll give you 2 options. Since you're so anxious, we will put you to sleep through the surgery. Okay. But before I put you to sleep, I might give you a small injection in your neck. I might leave a small catheter over there, a small little tube there. And we can do the surgery.
And what my esteemed surgeon want to say, what he usually prefer for his patients in this? Dr. Gaurav.
So normally, for all shoulder patients, immediate post-op pain relief is the major concern. They are painful surgeries. So I would want very good pain relief at least for the first 24 hours. And I usually send all my patients home the very next day. So what I want is that the arm should not be paralyzed when the patient's going home.
Sir, do you prefer general anesthesia or the regional anesthesia as a sole?
Usually a general anesthetic, because some of the shoulder surgeries can take a while, and if somebody is lying still in a beach chair position, it can be quite uncomfortable. If you also try to just sit still for like 30 minutes, you want to shuffle around a bit, and then you find the surgeon is shouting, and then they blame the surgeon for shouting. We are very genteel people.
Can I have Shishir, the anesthesiologist, back?
Yeah, same question.
Okay. No,
I will tell you later.
The question is for Shishir, the anesthesiologist. Does your surgeon shout because you keep your patients awake and the patient is thrashing?
I will tell you. Later on I will tell you. Sir, your choice. What will be your choice?
Yeah, I still prefer a general anesthesia. Why? Because when you are operating on a shoulder, I would want a good muscle relaxation at times also. So because I need to, when we are getting into the inserting the portals or doing something, so I would still want a good relaxed patient is much better for me. And post-op, I would still not want a paralyzed limb. I will just want not a paresthesia, but just a pain relief so that patient is pain-free for first 24 hours, definitely. That's what the plan of action would be.
And Shiva, you are excellent in...
So now as far as shoulder procedure goes, except a proximal humerus or arthroscopy, we do GA plus block. We never do awake.
Okay, sir.
Because as they said, and anybody can understand, being in a lateral position for 2 hours or in a beach chair, it's going to be uncomfortable for anybody. So we need to equally treat their mind as well, not just the deafferentation alone. So GA plus upper trunk block will satisfy all our requirements. The hand is not fully paralyzed, it's only the shoulder.
Either supraglottic airway or will you intubate me?
If it is a beach chair, the supraglottic airway is fine. If it is on the lateral position for a longer time, I would prefer a endotracheal tube.
Okay, okay. And Shiva, will you prefer same for yourself as well?
Sorry, I couldn't get you.
If you are at the receiving end, suppose
Okay.
you are the patient,
Okay.
will you prefer same with your same and
plan.
plan
Yeah,
of
yeah.
anesthesia?
So since I am giving a,
Same for Amjad for you?
Definitely.
so
And
since I am
also-
giving a,
There are two things here. Even if I wasn't anxious, I would want my surgeon to be comfortable when he operates. And both the surgeons have said that they prefer general anesthetic. Nobody likes, that they're already concentrating and doing something and the patient says, I want some water or something. So you have to look at the most efficient way to get your surgeons to finish up fast too. And when your surgeons prefer a GA and you can pretty much GA most people, there's no reason not to GA them. I think that combination, and if they don't want dense blockade, putting a catheter in there, running a very light blockade, and even if it's for 24 hours and they're staying in the hospital and you want a low density block, you could put in a cath and be done with it.
A small question for Dr. Amjad. See, when you put in a catheter and you get a PCA for a patient, so how long does the catheter means how do you educate the patient about the catheter? Because here the catheter tip is going to be a very, very small one, and small alterations may just rip off the catheter at any point of time. Because we have seen here, because we did a reverse shoulder 2-3 times, so we just put in a catheter, but by the time I come for the evening rounds, the patient is shifted and the catheter is into the hands. So what is your take on this, like giving a PCA with a catheter? How do you manage that?
So what we have today, we demonstrated that there's a different catheter available now, which is a lot more secure where it is. There's a completely different science on how to fix the catheter, and especially in the interscalene, because it's very shallow, right? It's about 1 centimeter deep in. You need to keep the catheter about 1 centimeter in itself, and you do this, it's out.
Yeah.
So we go through the middle scalene muscle, so we leave a lot more of catheter inside. So these are a lot more secure. Yeah, that is one. Putting it in the supraclavicular area is again a little more better, a lot more of catheter stays inside. In terms of PCA, you're talking about PCA opiates, right? So what we also do these days is we put PCA with the catheter infusion. So in case the infusion rate is not good enough for the patient, and it's always in the middle of the night that they have pain, they just press the button and the machine boluses 3 or 4 ml of local anesthetic, which is good for recharging the brachial plexus blockade. So there are little things that we've done. We understand that the interscalene area for shoulders is notorious for catheter slippages, but there are some ways out for it now.
Sir, which position would you prefer for shoulder arthroscopy, lateral position or beach chair? What?
So, I do most of my arthroscopies in beach chair position. Occasionally, I will use a lateral position, say if
What are
I'm
the-
doing a stabilization or something.
What are your concern? What are the advantages of beach chair position if we compare with the lateral position? Are there any advantages, and what are the harm in lateral? Because we anesthetists are more comfortable in lateral position compared to beach
Yeah.
chair position.
I mean, the main reason why I do a beach chair is because I was trained on it, so I'm more familiar with it. And beach chair for rotator cuff, for accessing the back of the shoulder, because sometimes I do a lower trap transfer, or if I'm doing something, I have to change my approach to the surgery, allows me a little more leeway. When you are doing a lateral position, there are certain limitations. So I find it's a little more, for surgically, I find it's a little more, gives me a little more leeway. But yes, beach chair position is difficult to achieve. Good beach chair position is not easy. I have to have my trained technician to do it all the time for me. If he's not around, then I find it very difficult, because it's not a easy thing to get a good beach chair position.
And so your preference?
I prefer a lateral position much more than a
Why?
beach.
Why you?
Why?
prefer-
Because
you are a good surgeon. You are a very good surgeon.
see, it is all about training. Like Dr. Gaurav has said, he is being trained in a beach chair position. I am being trained in a lateral position. So it is actually it is, you can do it in both, but it's your training that matters. See, you do some steps in a different way. He does some steps in same steps in a different manner, same procedure. So it's all about training, how you are being trained. But for me, lateral is much better because I find it more comfortable for every one of us.
Thank you. So, let me tell you why my surgeon shouts in the operation theatres. My surgeon is very finicky, and he keep insisting on very low blood pressure during beach chair position. He always requests for a blood pressure around 80. He usually say, in Germany, anesthetists are very efficient. Their surgeon get blood pressure of 80. So how much blood pressure is safe in beach chair position? How low blood pressure is safe in your opinion?
As low as my anesthetist can achieve it.
So, doctor,
You see, your orthopedic surgeons are least bothered about heart rate, blood pressure. These are just things which get in our way. We would prefer to operate on cadavers, because it's bloodless.
but my surgeon is definitely, he is very concerned about my screen rather than his own screen.
So am I, because I don't want a high blood pressure. You see, in shoulder arthroscopy, one of the limiting factors is, one tiny little bleeder will raise the surgeon's BP like anything. Because you just keep finding it and buzzing it. If your BP is very high, you have to increase the pressure of the fluid, and that makes the surgery more and more difficult the longer it goes. So all these things start a vicious cycle for us. So if the BP is low in the beginning of the surgery, it just makes things very, very efficient.
So Shiva, how much blood pressure we should? You will allow
No,
for
there
my
is,
surgery.
see-
For my surgery, yeah.
See, there is no such thing, and even the pressure is not directly related to the bleeding as well. So if I achieve a good deafferentation by giving a block plus GA, automatically my blood pressure is on the lower side, at least 20 to 30% from the baseline. So instead of looking at a predefined target, if you look at the field, even with mean pressure of 80, 90, sometimes field will be very clear. Even with that pressure, sometimes bleeding will be more. It is not predefined, any value matters. So my target would be a good working block plus GA, that itself will give a better field.
I'm just,
So I had a finicky surgeon just like this once upon a time. And we were doing a case, and suddenly from across the blood-brain barrier came a comment, "Hey, what are you guys doing? This field looks absolutely amazing. I can't see, there's no bleeding at all." And then we looked and we saw the patient was having anaphylaxis and her blood pressure had dropped to 20. Okay, so we had to lift the screen a little higher and go about our business. But yeah, as Shiva said, that having a block on board with the GA is going to drop the pressure. I think the trouble more on our side is keeping the blood pressure up to some sort of physiological level where the patient functions and not wind up with a
is there
problem.
any upper limit of the blood pressure? Means how low you can do? How low you can do?
So it depends on the patient, what you started with. If a patient
Myself is the patient.
Yeah,
See-
what's your blood pressure then?
My blood pressure is normal. Right now it is not within
How
normal.
often do you- I'll start questioning you. So are you a hypertensive? Are you?
I am hypertensive. Yes,
Okay, so what's
I am
your-
on ACE inhibitor and
Yeah.
on ARB.
Yeah, whatever you take, what's your normal pressure when you check it at home every now and then? So what's your normal pressure?
It is around 110 by 64, 70.
All right. So
Yeah.
then I would probably not want to drop it more than 20 or 30 points beyond that baseline. 20 or 30 millimeters below that baseline. So you look at the baseline and then you work with that.
So any additional monitoring, like any invasive monitoring, will like.
Not
For
for
what?
an ASA1 patient if he's coming for surgery.
I am not a one
Okay,
patient.
we are back to that. I look at you, I see Sishir, I can't see a patient, I can't get over, I can't unsee this. All right, I would probably not, unless I've gotten myself into a rut where we've started with a certain blood pressure and then it's just not coming up, and then for a long period I've been struggling to keep the blood pressure up, then I might slip in an arterial line with the other hand under the drapes, but probably not for a straightforward surgery.
For elderly patients, do you always?
Not routinely. Not routinely.
Sir, Shiva sir, you?
So, I mean, definitely the shoulder arthroscopy, it's not required at all. See, as Amjad said, if we a good working block plus GA, we will be struggling to maintain the pressures. So, all the times it is very easily we can get the systolic about 90. So, I don't think we require any more invasive monitoring for that particular procedure. If you don't have a block, so that is I wanted to emphasize, if the deafferentation is not complete, then you are going to struggle to decrease the BP. If any anesthetist is struggling to decrease the BP, it just simply indicates the deafferentation is inadequate. If you do a complete, do you mean what I mean by deafferentation? I wanted to cut all the afferent signals from the surgical site. If you do that, plus if you administer GA, you will be always struggling to maintain the BP. So all the time I will do that. We use a noradrenaline infusion to keep the BP up. Heart rate will be all the time 40, 45, 50. BP, unless if I have 0.02, 0.3 NORAD, it will be dropped to 70s and 60s. This is how I manage the case. It's not just the shoulder, all the laparotomy. We do a full dose epidural plus GA. So we always struggle to maintain the BP with NORAD. On the other hand, I have seen many people, they are using an NTG to decrease the BP. If you don't have a block on board, if your deafferentation is not complete, you will be struggling to the hell, and that will cause the bleeding. So this is, we have seen n number of times.
So my physiotherapist friend is here. So when will you start my physiotherapy, and when will you start my physiotherapy?
Sir, ideally in shoulder arthroscopic cases, we start physiotherapy after 24 hours of surgery, sir.
After 24 hours?
Yes, sir. So physiotherapist relies on anesthesia, sir, for effective pain management that enables the patient to participate in rehabilitation
So
program.
it means effective pain management is required for good physiotherapy?
Yes, sir.
Yeah?
Yes.
So do you want any catheter from our side? Any?
Sir, just for interruption, we also have Dr. Ramesh, also both physiotherapists, so we can ask the question.
So do you want any catheter from our side? For
Yes, we can try, sir, for the effective pain management, but cold compression also play a major role, sir. After this exercises program, we can implement cold therapy also. That also help.
For how long this physiotherapy is painful after the surgery? I'm a patient, I want to know everything.
Ideally, sir, if we talk about VAS scale, 10 out of 6 or 7, it will go for next 3 to 4 days, sir. And later on, the moment we start mobilizing the joint and working on the muscles, so gradually that it decrease, and up within 2 weeks, patient normalize almost 80% pain.
Thank you, thank you. Oh, sorry, I forgot to tell you. I'm a chain smoker. I'm a bad guy. Basically, sometimes I have to take this puff for COPD. I'm a chronic smoker. So, Dr. Amjad, now will you modify your plan?
I'll ask you to find another anesthetist because okay. So then you read the patient their rights. Okay, you tell them that because of this there are issues that can happen. So how bad is the COPD? How bad is your COPD? How many cigarettes do you smoke in a day?
chain smoker, mentioned here.
Are you smoking right now? So I definitely
This
will
hospital will not allow me to smoke here.
So I will modify the plan. I definitely would modify the plan a bit. Definitely here now you're looking at issues with phrenic nerve blockade. So you're looking at more distal approaches, like I said, and reduce volume, reduce concentration. If you're looking at a catheter, then you're looking at a more distal site. You're looking at options to redo the block. If you're doing single shots and not able to place a catheter in this patient, you have the option of putting, a block a little later after your primary block has worn out. I would still do the general anesthetic, but I would titrate down to looking at lesser opiates, rely more on my block for the analgesic, probably not intubate, use a supraglottic airway in this case. So a whole lot of things just to turn it around. It's just that because he's a chain smoker and it depends on how much of the COPD is. In today's practice, it's very difficult to find a patient who isn't smoking. Most of them smoke, and most of the time it doesn't significantly create issues for you to deny them or take them out.
Out of all blocks which you enumerated us, which block you will prefer?
Again,
Which phrenic is sparing strategy will you prefer?
based on today's
discussion,
talk,
your talk.
it would probably be a low volume, dilute upper trunk block.
And Shiva, Dr. Shiva?
My point is, especially when you see a case with COPD, respiratory pathology, that is where you should do the block. So don't, because of the phrenic nerve, don't go away. Because now, have you seen today morning, the ultrasound, we could able to identify all the elements consistently. So we have used only 5 ml, 4 ml into the upper trunk. As you can see from the presentation, that supplies the shoulder to almost more than 95%. So if you place 5 ml of local anesthetic into the upper trunk, that provide very intense analgesia for almost 24 hours. So pain-free postoperative period itself will not precipitate any bronchospastic episodes. If you keep these patients without a block, even while intubating, extubating, all the stress response will going to increase the chance of new episodes of bronchospastic episode than a patient who is completely pain-free and comfortable. So just because he has got some respiratory pathology, don't forego the block. With the advent of ultrasound, a low volume upper trunk block will be the best option for this particular patient.
And sir, as you know, I am patient of IgA nephropathy. I can't take NSAIDs.
So that is definitely all the more important. We need a regional anesthesia on board. So if he is a COPD with some sort of a renal dysfunction where we can't use an NSAIDs, so definitely the low volume upper trunk block has got a benefit of phrenic nerve sparing, giving an intense analgesia. So that is the best option for him.
For next day pain?
Sorry?
For next day?
Yeah,
for next 2-3 days pain? What?
True. The upper trunk block will last maximum 24 hours. After that, we need to look at it now. Either as we did today morning, if we place a catheter and then use a more dilute local anesthetic subsequently, we can get the advantage of regional anesthesia ongoing, keep it for 2 to 3 days. So that is the option that we have.
Now, Amjad, will you want to place any catheter?
We could. See, if you're saying NSAIDs
should or could?
We could. It really depends on your plan. You need to discuss these cases with your surgeon. You need to ask them, when are you sending the patient home? What exactly are you doing inside? Again, we sometimes fail to communicate with the surgeons effectively enough to understand what they're planning to do with the patient. What have they told the patient? How many days are you going to stay in the hospital? You can't have a different plan from what the surgeons have. You can put a catheter even for if your patient is staying for 24 hours. You saw it's fairly easy with the devices that we have to place in a catheter these days. You put it in, you run low volumes or you run low volume boluses in there, low volume infusions. There's a whole lot of things that you can do. So if you feel that this patient is overtly sensitive, cannot take opiates, cannot take NSAIDs, you're left with paracetamol, Can't happen, put in a cath. Simple as that.
What are those patients? Sorry, what are those patients where you need to block lateral pectoral nerve? Basically, what are the indication to block lateral pectoral nerve during this for this shoulder arthroscopic surgeries?
So it's a little some certain structures are innervated, as you know, the soft tissue structures innervated by the lateral pectoral nerve. Now, if you look at a surgery and say the surgeon is saying, I'm only going to do this in this spot, it doesn't work out that way. It's very difficult to do individual targets. Most of the time the suprasaplar and axillary will work, but when you find that certain patients have pain beyond that, then it's possibly that a requirement for those things happen. And because there's so much dissection and whatever goes on, the trauma caused by surgery, sometimes it's difficult to individually target those structures. If you want to block the entire shoulder in a distal approach, then you do all four, as you say. But again, very specific, it's very difficult to say this surgery requires a lateral pectoral nerve block. And
it supplies acromioclavicular joint, anterior part of acromioclavicular joint. So
yeah, but again, that's not going to be the only individual nerve that you're going to block.
And along with the all.
Along with
the all.
Yeah,
yes,
probably.
Definitely.
Yeah, one of those.
So probably now I got my solution. Now I'm ready for surgery. Now all of you know know him. He Adam Hedgick. He is the founder of the Nasura Society. So he met with an accident on 11th August 22 during a sport, and he was diagnosed a rotator cuff injury. So he was planned for surgery, and he had to choose his anesthesia. हम दोनों बराबर हैं, हम बराबर. His answer for this surgery. So his fellow asked about what will be your choice, sir, and who will give you anesthesia. So his answer for this was to block by the person who routinely give this block. So he chose his trainee. So look, his trainee is giving him intestinal block along with the catheter, and he is fully awake during the surgery. And after the surgery, his experience is, I had walked into the surgery at 8 a.m. and by the 10 a.m. I was out of again in my car, being driven to the shopping mall to do some shopping. And that evening we received few guests from overseas, and they followed. I joined them to sightseeing trip for New York. And if I had to do it all again, would I choose the same technique for anesthesia, which means he is very comfortable with intestinal catheter. Thank you.
Thank you,
Thank you all of you.
Thank you everyone for that excellent discussion.
I'm just taking an interruption. Mr. Amit Singh, Group CEO, is here, so I just wanted to introduce to the faculties so that they can have a.
Thanks for coming, all of you. It's been a pleasure. I mean, yesterday we were there, and really thank Dr. Anshuman for taking this initiative. And seeing such a eminent faculties from different hospitals and different cities, we are really honored of your presence. So thank you very, very much for that. I won't take much time. I think this session going on. So thank you once again. Thank you very, very much. Thank you.
Thank you, sir. Ladies and gentlemen, before we start the next session, we are fortunate to have amongst us Dr. Deep Arora. Sir, may I request you to kindly help us in felicitating our faculty. May I ask the faculty to kindly stay back. First, the speaker, Dr. Amjad. Sir, could you now? Thank you, sir. Dr. Shiva Sanmugam. Thank you, sir. And Dr. Shishir Agarwal. Thank you, sir, for an excellently moderated session. Thank you, Dr. Deep.